Great, thank you so much and welcome everyone. It's so good to have you here for our final TA session. Quick disclaimer, the event is being recorded and it will be available afterwards for on-demand viewing. And if you have any questions you'd like to ask during the presentation, stay on mute and you can message us directly, or you can wait for the question and answer period that will be happening at the end of the presentation. Welcome to this session, which is on optimizing the HIV client's telehealth experience. This session will cover the HIV client experience with telehealth, which includes HIV client attitudes towards telehealth, strategies for client engagement and retention in telehealth, tailoring messaging around telehealth, rapport building via telehealth, and best practices for telehealth navigation. And as I said earlier, you can submit questions in the chat box or just wait till the end and we will have a facilitated Q&A session at that point. So our wonderful speakers here today are Dima Dandachi, who is the medical director of the HIV/AIDS program, the University of Missouri Healthcare, and Alishba Basil, who previously worked as a telehealth navigator at the University of Florida, Jacksonville. And so without further ado, I'm going to pass it over to our first speaker to begin.
Thank you so much for the introduction, and thank you for having me. I'm really happy to be today, talk about my experience and talk about what I heard from people talking and their attitude about this, my research and my work, and kind of walk you through it and hear from you as well if you have any questions or your own experience in telehealth. And I'm sure each one of us now have like more experience in telehealth. So next slide. So I'll tell you how this is all started. It was weird because actually when I was interested in telehealth, that was really before, long time before, people started talking about telehealth. I was doing my infectious disease fellowship and training at Baylor College of Medicine in Houston, Texas. And I had the chance and really opportunity to work with this kind of wonderful mentor, Dr. Giordano, who is very well known nationally about retention in HIV care. And this is his focus. And he was kind of he was my mentor when I was doing my training. And we started looking at, we know that retention in care is not optimum. How do we improve it? And what about telehealth as a solution of this? And I started doing the research saying, okay, telehealth would work maybe for a lot of people, but before saying that, let's see what people think about it, and to explore their attitude about what do they think about telehealth in order to get their care instead of in-person visit. And that was started from February to June 2018, and we did it in Houston, Texas. So the clinic that's affiliated with Baylor College is Thomas Street Health Center, which is a very big, one of the largest actually clinic, HIV Ryan White clinic that kind of serve almost 5,000 to 6,000 people living with HIV. But remember, at that time, none of the patients had really previous experience with telehealth. We had to, even when trying to kind of submit, put the survey together, we needed to explain to people what telehealth means. None of them had previous experience, and we would say, oh, this is a video, like if you could see and talk to your provider over a video, or something like we would say chat. So we would give them like different explanation in order to explain what telehealth is. And next slide. So what we got is, so this is what we were talking about, like retention and care. Probably most of you have seen this slide before. Probably retention and care and the HIV care continuum is the lowest to the target of 90, where 90% of the people diagnosed, retained in care, and 90% virally suppressed. So you see it is the lowest. And retention and care barriers are probably not very specific only to people with HIV. I mean, probably this is for all cases and all, patients who have to deal with chronic care and long-term care, and they needed to see their doctors kind of often, same as diabetes or any other chronic disease. But we know that for people with HIV, we have like a large share of probably people who are from racial ethnic minorities, low income, low health literacy, and so on. So all the factors that we talk about, it's even more exacerbated, more pronounced when it comes to the population of people living with HIV. So the literature on retention and care is extensive, and you would find a lot of papers and reviews and so on. But the thing that was kind of consistent when it comes to retention and care is transportation challenges, competing life events. It's time consuming. I mean, think about it. Like my provider, my primary care have a regular business hours. And how difficult would it be to just like take almost half day? Because like, think about it, it takes half day to actually come to the clinic, park, come in, check in, see the nurse, see the doctor. I mean, it takes half day, and that's being conservative. Like just if you don't add to it, the driving distance as well. And that's kind of like all was similar, but also when we talk about, rural areas, this is even more exacerbated because like this is not something like very common. We didn't see it that much, and you don't hear about it that much in urban areas, which, like you have probably more HIV care providers compared to rural areas where they have to like drive up to 90 minutes. And that's an average. We're talking about like 69 to 90 minutes to come to an HIV care provider. And I will tell you, after I finished my fellowship, I came at the University of Missouri for my first job, actually. And I will tell you, 90 minutes is even very acceptable to people. Like some people would drive 2 to 3 hours to see us in the HIV clinic just because there's no one else, or because that comes to the next point, the stigma. Like all these places, like the small towns where if you want to even pick your medication, the pharmacist would know you have HIV, and the pharmacist is your mother's friend, and so on. I mean, it's the stigma in rural areas is much more higher, and especially targeted to people with HIV and to the LGBTQ community. So it's definitely more significant. But for example, in Thomas Street, the problem with the clinic is not like urban versus rural, but the problem with it, because it's a very large clinic, it's a comprehensive Ryan-White HIV clinic. Everyone knows that if you go to that clinic, that means you have HIV. This is the majority of people, like very few like would go for PrEP, but this is kind of the majority. So last time I was talking to a provider, they said they even make a rule that no one gonna mail anything that has the address from Thomas Street, because you will be breaching confidentiality by getting this mail to people. They would know if someone else see even the mail without even saying anything, they would know that they have HIV. So we said, okay, great, next slide. So really telehealth would work with all these barriers, and it would work for the transportation, for the stigma, and so on. So we asked people to address, like to say, what's your attitude, as I talked about, and we had a response of 371 participants completed the survey. The median age was like 51, 36% female, 63% African-American, 26% Hispanics. So I don't know if you could click and see, like I had some, I don't know, because of the PowerPoint, it's not attached. No, probably not. Okay. So probably we don't have the numbers on the circle, but I cannot remember them. So we had, if, I don't know if you probably don't see even my curse, but so we have like almost 36% of people said that they very likely, look, we asked them how likely to use telehealth. 36% said they are very likely to use it. Some 20% said they will likely use it, but you still have like this small proportion in orange up, it's like 17%. They said very unlikely to use telehealth. And like also another like maybe 13% said unlikely to use telehealth. So the majority, it was a positive attitude. And that's again, people not knowing about telehealth before, but you have this percentage of people that said unlikely, very unlikely to use telehealth. So we started to look at, okay, to explore what are the attributes that make people wanted to use telehealth or not. And this is not related to experience. It's mostly like what are baseline or what characteristics of these patients would let them say, I would use it, I would not use it. Next slide. So what we find out is that if you, next slide, please. Thank you. So participants really said like, okay, there are great benefits to telehealth, but the factors that kind of affected whether they would use telehealth or not, as you would expect, people who are born in the US versus born outside, they have a higher educational attainment, higher HIV related stigma perception, definitely prefer to use telehealth, or said they would be more likely to use it. But the thing that was surprising to us is that the age, sex, race, income was not associated with, likelihood of using telehealth. But also, as expected, if they didn't have a device, if they don't have internet, if they have limited data plan, then, or they're not familiar with this technology, it was a barrier to them for 30% of respondents. But remember, like we did all this telehealth to say like, okay, this kind of reduce the barriers in order to get people retained in care, get their medication, get virally suppressed. But remember, these are mostly clinician-centered outcomes, right? For a patient, it doesn't matter too much. So there was no association between participants' uncontrolled HIV, medication adherence, and likelihood of using telehealth. So it's not like, okay, if people had like, difficulty taking their medication, having their HIV controlled, they would be more likely to use telehealth. It really didn't matter. So for us, it's kind of like, this was surprising because there is one thing to be satisfied and happy about telehealth, and there is another thing to say, like, is it going to affect the outcomes that clinicians are looking at, not only satisfaction, quality of life, and so on. Next slide. So now with the COVID, that kind of, and this is kind of, we published this article 2019, then we published another article saying like, okay, how are we going to implement telehealth in the patient HIV from almost like from clinician perspective, do like what set of patients we would offer telehealth or not. And that was, as I said, before the COVID, and then COVID hit and everyone now using telehealth, and we shifted very rapidly. And if you look at the literature, I mean, all the experience with telehealth, at least the published ones, right? They're very positive. Whatever you look, it's a positive experience. Even like in like I just pulled this one, and it's like a 90% of the study, 91% of patients reported effective communication even with their provider, which was something that people would say, like probably not really something that could be affected with telehealth, but seems like not for 91% of patients in this study. I mean, many of these studies, remember, have small sample size, or they done, for example, like in one institution versus the other. But even the ones that are more nationally, kind of like in more broad base, they also showed a very good experience. And 67% indicated that their telemedicine visit was more convenient than a clinic visit. Next slide. So this is, and when I really got my job here, I didn't think about telehealth as a big thing, but for my own advantage, really, the University of Missouri, they are really big in telehealth, and they are really very advanced, and they have the infrastructure to support it. And so if you see here, like this is our telehealth visits, not only in the infectious disease or HIV, this is all family medicine, internal medicine, subspecialty care. And you see in February 2020, they as visits, they had 0% telehealth. And you see how this kind of started increasing. The peak of COVID in Missouri kind of started a little bit late. So you see like in April, this is when actually like the highest number of telehealth visits happened with 87%. And I will tell you, in the ID clinic and HIV clinic, actually it was 100%. We closed the clinic totally, and we said, we're only going to do telehealth. And we shifted like 100% to telehealth. This again kind of started, like, I think the trend in all the US, kind of we're seeing back the in-person going up versus the telehealth. But then we thought, okay, let's look at something like more kind of closer to, in the next slide, like what we asked is that let's look at the no-show rates. Yeah, but before that, so I won't tell you, like, because I kind of saw this slide from the CMS, and this is just showing the number of telehealth visits for Medicaid and CHIP beneficiaries from March to June 2020. And it shows that Missouri has the highest, actually, like telehealth visits. And I told, like, I was kind of like, I said, probably University of Missouri had half of those. So it's really, they were doing a lot of telehealth. And as I said, our experience was, we totally closed it. So, but again, going back to this help patients being retained more in care or not. And I want to make the differentiation, like these two are totally different, whether satisfaction, experience, does it translate to more retention in care and more no-shows and so on. So I asked my team in the next slide, I asked my team to look at kind of like the no-show rates. Again, this is not the next slide, I'm sorry. So this is just shows in at the University of Missouri in Boone County. Like this is where we are, like the green, darker green. And this is where their kind of outreach of telehealth visits, people coming from all these zip codes. So you could see like it's all over really Missouri. And they came up with this kind of numbers that like how many miles this have been avoided. I mean, it's tremendous. So next slide. So what really made it successful? And I think what made it successful is the infrastructure that we already have. The organization was really big on, I mean, we have the Missouri Telehealth Network since the 1994. And I know that we were supposed to talk today on the patient satisfaction and attitude, but this is what I want to get at. Because we had the good infrastructure, because we have the organization was ready, we had a telehealth dedicated team, then once the telehealth, I mean, we were able to switch like very smoothly, very easily. And really the providers loved it. First, because we had the support that we needed, the patients had the support. They distributed even hotspots in all over Missouri. They helped rearrange the workflow. Providers didn't need to do any about this. And so that really translated into provider satisfaction and at the end to patient satisfaction, because we were able to do even this from home. I mean, I know that other institutions would not allow them, for example, for providers to work from home, but we did. I mean, you could do it from office, from home, from clinic, whatever you want. I mean, they left this for us. So it just made it very kind of smooth and easy, that made it on the patient side also being satisfied and happy with the experience, overall experience, and able to communicate. I mean, we did 90% of our visits were actually video visits. So when I spoke to other people, it was like mostly like phones. And in video visit, you know, like I actually was able to connect to people more because I was able to see their house. I was able to see the environment they sit in, their families, sometimes families who would not come to their appointment with them in a regular day, but they would be sitting there. And let's say, for example, like a patient forgot about what medication and get confused what bottle he's taken and what, you know, something like this, then they would go grab it and show it to me on the camera. So it really, I think it added to the communication rather than the other way around. But you could imagine, like, if all our visits and telehealth visits were only a phone, I mean, even if, for example, we don't have really studies that kind of compare, let's say, in-person versus phone versus video visits, not like a robust kind of type of you know, studies, but still, I mean, it's common sense, right? Like how much you're going to be able to connect to someone if they come to see you every 6 months and all what you would do is like call them over the phone for 5 minutes. So it's really it's a kind of common sense. Like if you're definitely the connection is going to be different, and you're not able to get like the verbal non-cues, like, you know, like the non-verbal cues, their environment. I mean, as I said, I mean, phone is totally different than video, and I think that also what helped us and what helped patients as well like the experience. Next slide. So this is the one I'm talking about. Probably I put it in the wrong order. So I told my team to kind of check about the no-show rates. And I don't know, like for most people on the call, if you do HIV versus ID alone, or how your clinic composition is, but we do both. And you see, like in, you know, always the no-show rates, unfortunately, is much higher when it comes to the population with HIV, as we said, because like probably we have much higher also like challenges, vulnerable groups, and so on. And I said, okay, so that's in general. The first kind of graph is like in general, you see how the no-show rate is much higher, the blue one with the HIV population versus the general ID, non-HIV. And we said, okay, let's look at the no-show rates, comparing these 2 years between May, June, July. And you would see that there was actually like no-show rates has decreased with telehealth, but it wasn't sustainable response. I mean, we had like going from 3%, which is significant, especially in a bigger kind of clinics. But then this gap started collapsing, and actually it reversed when it came to July, where the no-show rates were much higher in telehealth compared to in-person visits. Next slide, please. Thank you. So, and this is where we like started looking at what are the barriers to telehealth. If we're saying this kind of works for, transportation, all of these things, good things that we talked about, why then people are having issues even to show up on their telehealth? But the thing is, I think like we were kind of like not being on the ground, knowing what's going on, because, and I'm sure many people talked about this before me. I'm not going to repeat the same thing, but, and you probably know that from your own experience. But the people who don't have money for transportation probably don't have money to have high-speed internet and have the best device and best camera as well. And if they have low health literacy, they probably have low also digital literacy as well. So really, unfortunately, what we're trying to achieve as barriers to detention and care are the same barriers exist in the same population when we talk about telehealth. So how much we solved, I don't know. But again, that's different from patient experience. Next slide. Thank you. So I started working on research to preparing actually for a research to see like, telehealth for patients with HIV in different institutions. And when I came out of my bubble at the university and started talking to patients and to physicians outside of the institution, I feel, I mean, not everyone had the same experience, and probably even the opposite experience. And I, in preparation of this research, I had to speak to stakeholders, clinicians, leaders, and patients. And I'm just going to give you like some quotes of people, what they told me. So one patient was telling me, it's hard on me. This telehealth changed my relationship with my doctor. I don't like to feel rushed. I'm an HIV survivor for 27 years, and I had a great, like she was explaining to me how great relationship she has with her doctor, but this has changed it. I was talking to an HIV provider in another institution, and she was telling me, even if I tried the video, so like I was kind of asking what telehealth means to you, what type did you use, and so on. And she said it was like 99% like phone, because even if I tried the video, it was very painful for myself and the patient. She said, like, I would give up on it. And then she said, speaking more to my personal experience, I honestly do not like telehealth. And this is me just being totally honest. And I think because they thought like I'm kind of like asking their opinion, I'm looking for telehealth, and like they think like they were going to give me a positive experience. Another clinician told me, I would estimate, and quote unquote, said like, perhaps I'm negative, but I think 30% of my patient will never be able to do telehealth just because they do not have the level of education. And this is another patient, like 60-year-old person living with HIV. She was saying like, it affected my mental and emotional health because I would spend more time on the call agitated because it's all new to me. She Karen Lowe said like, the technology is something I struggled with all my life. I'm more of a visual person, and no one showed me how to do it. If people are poor, it does not mean they are stupid and can't learn. So that's all I have actually. So hope you kind of got like the different experience really through that, and that's all. Thank you so much.
Great, so we will turn it over to our next presenter. Thank you so much, Dr. Dendachi.
Yes, thank you, Dr. Dandachi. That was a great presentation. I think I'm going to be probably echoing a lot of the sentiments that you brought up. I actually was the telehealth navigator on the UF Health and CDC partnership that we actually had starting in around 2016, 2017, and culminating at the beginning of 2021. It was a telehealth program that was specifically focusing on increasing the access of healthcare to minority persons in urban Jacksonville. My role as a telehealth navigator was really patient facing. So I was day in and day out in the clinic, kind of assisting patients with any technical issues that they might have, providing that initial education to them to get them enrolled in the telehealth program. And of course, also providing assistance to our providers as well in their ability to join virtual visits, that sort of thing. So we can go ahead and go to the next slide. Thank you. So this was funded by the Centers for Disease Control and Prevention. I just want to put that disclosure out there. We can go to the next one. And of course, I'd like to acknowledge this was a very large project that took a lot of different individuals' input, as well as hard work. We had a lot of community organizations that contributed a lot to our program, as well as marketing teams. Of course, CDC and HealthHIV were very important partners as well that assisted us with capacity building. I do have our project director, Dr. Graywall, there as well. It was a kind of a partnership between our Community Health and Family Medicine Department and our Center for HIV/AIDS Research, Education and Service, UF Cares. We can go to next slide. So just an overview of my presentation. I'm going to kind of first start off with an overview of our telehealth program, then delve into some patient perspectives, and then round it out with some lessons learned. And we can go to the next slide. Thank you. Next slide. All right, so just to start it off, this is kind of an overview timeline of how telehealth at UF Health Jacksonville has progressed over the years. We started off in the pediatric neurosurgery with a small pilot program, and then branched out into adult neurology, and then finally community health and family medicine was brought on board. At that point in time, also, we had a new telehealth educator, a nurse navigator, Miss Jessica Peters, who basically served as that initial kind of communication between patients and providers to start to really build the telehealth program at UF. We then had an Epic integration in 2017, and then we made a switch from our video conferencing platform, which was originally known as Video. We transformed into Zoom. So with this, previously how we had it done was patients would be sent a MyChart link as a portal message, and then they would click that little link to join the video's conference call. After the Zoom integration in 2020, they actually could just go ahead and go straight into their portal and click launch meeting, and that was allowing them to join the call with their provider. Next slide, please. So specifically focusing on the project that we had with UF Cares, it was a very big multi-departmental project. It required, again, a lot of input from a lot of different stakeholders. We had a lot of our community-based partners serve on our CAB. So that was our community advisory board. We had patients on that as well. From the beginning of the project, as well as throughout with the project, we had several meetings with those stakeholders monthly, as well as meetings with our core team from UF Cares and UF Community Health weekly to kind of make sure that everyone's on the same page, see when problems did arise, how we could combat those. The thing that was very interesting about this project as well was that since we had a lot of buy-in from our community members, we actually had a lot of presenting sites so that patients who did not have access to personal technology and personal cell phone devices were able to go to these different presenting sites located at the organization, such as the Nassau County Department of Health, the NFAN, Jasmine, a lot of these LGBTQ plus centers. They definitely allowed us to set up an iPad there, and we trained their staff at that location as well, so that they could assist any patients who had to have a visit, but maybe didn't want to drive all the way downtown. They could kind of, from that presenting site a little further away, could join the call from a private location with the help of a member over there. So definitely required a lot of hard work from a lot of different individuals to kind of bring it to fruition. Next slide, please. So when starting off this program, thankfully, we had a lot of this initiated, everything initiated actually before COVID-19 happened. So just like Dr. Dandachi's program, we actually had a little bit of an easier transition when COVID happened. We already had educated a lot of our patient population on how to utilize telemedicine. So the change wasn't as big for them, so they weren't as taken aback by it. We definitely had to make sure that our hardware, our software was completely established previous to implementation. The one thing that we did run into a lot of kind of roadblocks with was the legislation and reimbursement at that point in time. So when this project was first initiated, we had a lot of issues trying to get, a lot of our patients were funded back through the Ryan White program. So we had a lot of issues in our local Jacksonville Ryan White Planning Committee. They actually did not provide reimbursement for telehealth services. This was way before COVID. So they had not given, it was a lot of kind of picketing from our teams, the CDC teams, as well as HealthHIV to get the planning committee to start allowing us to have reimbursement in our clinics for these services. And thankfully they did by the start of this project. So that allowed us to actually provide this service to our patients. But that was kind of something that, like, when initially thinking about pursuing this project, it's so important to understand, you know, where the different funding sources come from for your patient population as well. And then of course, we also have on here translation services, making sure that there's there's always going to be the level of an accessibility to patients, just because the MyChart portal is in English, but having that option of having the language line translators, as well as creating educational materials in multiple different languages, kind of assists in making sure we have that infrastructure before we get started to see our patients. Next slide, please. All right, so this is actually an example of some of the patient education materials that we utilized. This was like a trifold pamphlet that I used to hand out to patients going through the clinic. It kind of went through all of the steps on how to get enrolled into the MyChart app. I would actually sometimes assist the patients in getting this access to this link. I had a little iPad on a cart I would roll around, get them all signed up for MyChart, send them the link to their phone, and then that would assist them in easily pulling it up. And I kind of wanted to like go through this with the patient while I was there. As we go into the next slide, actually, it is kind of like my favorite phrase that if you have educated patients, they're empowered patients. So it's very important to kind of put the power back into patients' hands, especially in something like this. A lot of our patients, again, were low-income patients, minority patients. So there was that barrier of healthcare literacy as well, but then the additional of the digital kind of barrier as well. So making sure that, like, as you are a telehealth navigator or maybe a case manager or a super user, making sure that you're not doing everything for the patient was very important as well. So kind of taking the steps, you know, this is the next step that, you know, you can go through. Why don't you go ahead and tap that on your screen? The little things like this kind of make the patient feel like they have their own autonomy, and allows them to, you know, make the decision, like, you know, this is how I'm going to use telehealth. And it helps them for when they're at home alone and they're trying to access the telehealth program. They don't have to give me a ring. They can definitely kind of navigate it on their own. So again, being that presence there is very helpful for their first time using telehealth. Maybe doing a practice one with them was very important for us. We had a lot of things set up like that for both our providers and our patients, having like a practice telehealth session if needed, so that they could just see how it looks if you are on the patient side or the provider side before you're doing your first one, especially since the majority of this education was done before COVID. No one was really as familiar with telehealth. So they definitely required a lot of assistance in getting familiar with the system. And we can go to the next slide. So now I'm going to go into some patient perspectives. I think this was my most favorite part about working on this project. I loved listening to all of the patients in the clinic with the negatives that they had about the program, as well as the positives, because it was just always room for us to improve and for us to take their perspectives and kind of see how can we build from here and make our program better and more tailored for our patients. So we can go to the next slide. So there were a couple of different ways that we gauged patient satisfaction. The first one was actually through the use of patient satisfaction surveys. So we actually sent these through the MyChart app. I would actually send a portal message to the patient with a link to a REDCap survey that they could complete. This was sent to patients who did indeed have virtual visits, as well as patients who had in-person visits, to see, what their difference in opinion was in satisfaction when completing the virtual visits. So we actually had a total of 92 patients who had a virtual visit complete the survey to assess their satisfaction with their virtual visit. 98% were comfortable with receiving their healthcare via virtual visit, and 98% actually reported enjoying the virtual visit experience as well. 85% reported not being worried about privacy. So it definitely, we had also around 100% feel that virtual visits actually saved time with them. So they did not have to, find childcare or figure out how to commute to the busy downtown area that we had. So it was definitely a very interesting kind of way for us to learn more about patient opinions with the virtual visit program. And then, of course, we have the majority, leaning towards satisfaction, but we did have some, as I'll go into later, some patients who did kind of voice their barriers, maybe hindrances that they felt were present with virtual visits. You go to next slide. Okay. So I'm going to just go into marketing a little bit as well. This was another way that we engaged our patients. We had a lot of these pamphlets, these flyers that we actually presented to our CBO partners. We would leave these at those agencies, as well as have them in the clinic. Now, the most important thing that we did with targeting these marketing materials, so just as you guys are probably familiar, the topic of HIV, unfortunately, is still a very sensitive topic with patients. So kind of making sure that some of these materials were very generic, in that they didn't specifically target patients living with HIV. They more so were just very generic, like this is our telehealth program at UF Health Jacksonville, so that they didn't feel like that they were kind of being forced to participate. Any HIV specific marketing materials for this program, we made sure we had them actually in the clinic rooms rather than in the lobby, just because of the stigma, unfortunately, that was even associated with patients visiting that area of the hospital. And again, having these very generic kind of information, even at the LGBTQ+ centers, et cetera, so that, they know that this is an opportunity for them, but it's not going to specifically kind of make them feel like they're being targeted or having to undergo any sort of stigma. Next slide, please. All right, so actually I embedded one of our patient videos here. This gentleman, actually, I recruited from our clinic. He was very willing to actually share his experience using telemedicine. I think this is my favorite part about doing the project. I love speaking with him and learning his experiences living with HIV, as well as, what he found positive about the program. But if we could play that video, I'll let him kind of take it away and show you guys, how he felt participating.
My name is James Berniker, and I've been living with HIV for 30 years. I was struggling with medication side effects, and I started going to UF Cares 10 years ago. When I first got here, I had to make appointments, and I didn't know the system. I always had to get in my car and drive 10, 15 miles to get here, and it was very, very difficult during that time. I'm an avid gardener, and particularly this time of year when it's cool, I get to go outside and I spend time in the garden. And if I have to be going to the clinic, it really blows the whole morning. I like virtual visits because HIV requires you to reduce your stress level. And the virtual visits, they are very easy. When I open the computer, there he is. And he can see me and I can see him and we hear each other. And it's like going to the office, except we're not there. And I love it. It's very private. They don't record it. I really like that part of it too. It was a real challenge because it took me an hour during rush hour to get to the clinic. And now, with the virtual visits, I don't have the stress of being in traffic, and I am comfortable during the conversation with the doctor, and I'm doing well as a result. So I'm 69 years old, and I'm in the best shape I've been in the last 20 years. So everything's going very well right now.
Alrighty, thank you so much, Marissa, for pulling that out. But yes, that was Mr. Berneker, a very sweet gentleman. He definitely kind of voiced a lot of similar kind of opinions that a lot of our patients actually. As we continue on, I'm going to be kind of going into some of the focus groups that we conducted at UF Health. It definitely continued to reinforce that idea that patients definitely found this to be a valuable avenue of pursuing healthcare. But if you don't mind, thank you. Yes. So, yep, a nice segue into our focus group. So we actually conducted 6 focus groups with patients who utilized telemedicine, as well as patients who were more so hesitant and had not, as of that point in time, utilized telehealth. So thankfully, actually, we were able to get all of these focus groups done before COVID-19, because when COVID-19 happened, all of our patients used telemedicine at that point. But we were able to get this unique perspective of people who were hesitant before the pandemic to use telemedicine, and patients who were very big fans of it and had adopted it quite early on. We can go to the next slide. So these were some of the facilitating factors that we learned during that those focus group sessions for patients who did decide to use virtual visit, which is what the VV stands for. They found that it minimized stigmatization, reduced their wait time, their privacy, concerns were also abated, and they also found it to be very convenient. They also, I felt, just again, going back to giving patients autonomy, on that MyChart app, it was a direct link to their portal. So they also had access to their medication records as well as their lab results. So it was a definite, like, if they ever needed a refill of their medication, with the click of a button, they can send a message to their provider to get that medication refilled. So educating them on that use of the portal was very, very impactful for them, because they were able to actually take that information and use it to continue to improve their medical, their capabilities. One thing as well with that MyChart app, we also had glucose and BP tracking sheets on there as well. So patients could actually track that measurement, and it would sync with our EHR Epic to basically allow for the provider to continue to look at the patient's self-monitoring from at home. So instead of them bringing in sheets of paper to you with their vitals, you can actually just see that from the app. So it was definitely very helpful for both the provider and the patient. And then, just like I mentioned too, the concerns of childcare. From an organization level as well, we had a reduction in our no-show rates, because it was we had that telehealth navigator as well as the medical assistants who were calling the patient, making sure that they were connected. No one was getting caught in traffic and unable to come to clinic. So definitely alleviated a lot of barriers for both us as the healthcare system as well as for the patients. Next slide, please. And then these were some of the patient barriers that were mentioned in both of the virtual visit sessions. Patients, still had that a concern of having lack of access for some individuals who maybe didn't have that personal device. Some individuals found the presenting sites to be very helpful, more so the patients who were located further away from urban Jacksonville, where the clinic was located. So we had a lot of use from our CBO partner in the Department of Health in Nassau County, which was several miles away. In comparison to the ones that we had more closely located to UF Cares, patients were more under the impression, if I'm going to go there, I might as well just come in person to see my provider. And then we did still have some concerns about privacy and security. And I thought that this was very interesting, because it was kind of a double-edged kind of sword. So some patients found that they really appreciated having virtual visits because of the increased privacy, in that they don't have to come to the clinic and feel the stigma of going to that specific floor of the hospital. Whereas some patients still found that, maybe they're living in a joint household situation. So they personally didn't want anyone in their family to overhear that, they had HIV. I had some patients who were were elderly. And so they were saying, my grandchildren have access to my cell phone. I don't want them to stumble upon my app and find information. And, explaining to them though, that it is a secure platform. It requires like double authentication to even access the app. Those types of things were, easy to explain, but unfortunately, you still have, some patients still have concerns. So definitely, that's still kind of like a place that could, use some work, but it's very, very interesting to see the different opinions, because every patient is unique and has different experiences with this program. And then, of course, with the telehealth literacy, some patients didn't feel, again, comfortable utilizing a lot of patients still had like flip phones. So they weren't comfortable, joining a Zoom call, doing the video call. They were, more so, why can't my doctor call me? But, I'd rather see them in person so they can do a physical exam, which is what that section over there with the quality of care too goes into, just because some patients were worried that that quality of care would be diminished using the virtual visit platform. We did actually do a lot of training sessions with our providers on how to use the technology and have that confidence to, help the patient when they needed help, as well as on common tips and tricks that can be employed to implement webside manner. So making sure that, you are actually staring directly in the camera in a way to kind of make sure that you're making eye contact with the patient artificially through the technology. And then, of course, technology changes were always kind of a thing that made both providers and patients a little hesitant, just because we did have, a lot of changes with our platform that we were using from video to Zoom. Next slide, please. So I'm just going to conclude with some lessons learned. If we can go to the next slide. I think the biggest one I would want to spend some time on is on the next slide for what we actually encountered with COVID-19. And we can go to the next slide, please. Perfect. So actually, when COVID-19 happened, previous to COVID-19, we were only offering virtual visits for our main physician visits. But since our clinic at UF Cares was actually multidisciplinary, we actually had case management services, psychiatry services, dietary services, pharmacy services, and we had a research team. We had quite a variety of different, we even had OBGYN services in that clinic. So it was kind of like a one-stop place for patients to get everything that they needed. So due to COVID-19, there was such a rapid increase in patient and provider and hospital demand to convert these services we were offering just for our physician visits to department-wide. So it was very important that we quickly kind of adapted and overcame this big change and demand. So I conducted a lot of training sessions with our different providers and our ancillary services. We had to do a lot of capacity building with making sure that we had enough equipment and infrastructure by building the specific ancillary visits in Epic for these providers so that they could also get reimbursement, because thankfully also at this point in time, Ryan White had opened up capability for case management to also get reimbursement for their services due to the pandemic and the crisis that we were undergoing. And again, we also did indeed convert 100% of our services virtual for some period in time during the pandemic, and to this day also continue to implement these tools, just especially with case management too. A lot of the case managers found it to be a very useful tool. They were able to continue to remain in contact with their patients on a more personal level while still being able to get reimbursed, obviously, for their services. So it was a very, very great kind of thing that we were still able to offer to our patients even during this pandemic. Next slide, please. And then finally, I think the key points is just making sure that there's some sort of efficient workflow in place when pursuing a telehealth program, from going from the patient registration to provider and patient education, and having someone, maybe not someone dedicated to telehealth, but maybe having more super users in your clinic. That definitely is something that is very integral to making sure your telehealth program can be a success. A lot of times, we have such a burden of different roles in the clinic that, someone, not many people can take on additional roles with telehealth education, et cetera. So having that dedicated individual in clinic definitely assisted with making sure that we had someone who could kind of assist when these types of small things, someone who was experienced with how to use technology. So they were able to serve as like that educational and kind of personal kind of recruitment person for the clinic, but then also for any IT issues that arose as well. So it definitely was a very impactful program on our local community here in Jacksonville, as well as in Northeast Florida as a whole. So I'm glad I was able to share it all with you guys today. And I think that is it from me for the last slides, and we can go into questions.
Great, thank you both so much. Wonderful information. Yes, thank you. So just why don't we go ahead and open it up to all of our audience members and see if there are any questions for Valeshka and Dima. While we wait, I know, Alicia, we had a session with Dr. Graywall, and a lot of people were interested in this, in the navigator position that you filled, and kind of the key, like what the key duties were, what a position description looks like, what the skills, required skills would be if you were to seek out to hire somebody. I wonder if you could just speak to that briefly. What is an idea? What does an ideal telehealth navigator look like, and what are they doing?
Of course. So it was actually a very unique situation because technically this was more so of a research project. So I was actually hired more so from the research standpoint of it. My degree is in biomedical sciences, more so from that science-based aspect of it. But I really enjoyed this project. I think it was interesting because I had that research aspect of it, because I did do, we did kind of work on some of the regulatory aspects of this, as well as with the analysis when we had our special evaluation towards the end of the project. But definitely as a telehealth navigator, I think it was more so a very unique clinical kind of perspective, where I actually, like, day in and day out was located in the clinic, was specifically focused on ensuring that I would actually most likely speak to pretty much every patient that would come in through our doors. I would, again, roll around my little cart and kind of get them to enroll in a telehealth program. So it was kind of an interesting role. I would work closely with the CBO partners as well to see if they had any questions or any barriers that they were running into. So I think, definitely an ideal background for someone who is a telehealth navigator, it can be something that's diverse too. You just need to know how to kind of connect with the patient and ensure that they're feeling comfortable, especially in this specific type of environment with patients living with HIV. It is already sometimes a very difficult conversation that maybe they have to have with their provider later on in the day. So making sure you don't take up too much of their time when they're in clinic, and positive energy going into their room as well. So and then being kind of technologically savvy as well, and quick to pick up these types of skills. I worked a lot with our kind of like IT team as well. They provided a lot of like education as well. And then ensuring that the workflow of your specific clinic, like when your provider goes in, when the medical assistant goes in. So whatever the perfect opportunity is for you to also speak with the patient. Again, it's always good to kind of work very seamlessly with that clinic environment, I think. And each clinic is different. Each patient population is different in terms of what they require and how much assistance that they need. But just being readily available, I think it was a very unique kind of role that they were able to establish for UF Cares. It definitely allowed a lot of their clinical staff to not have that worry of having to not only see the patient and complete everything that they need to do, but then also have to deal with all these technology issues, et cetera. So.
Right, and I think Latoya, you had a question. I don't know if you wanted to come on audio, if you just want me to read it out.
I don't mind running my mouth. I was just wondering, so I paid attention to everything, but I was very keen on the portion where you guys talked about some of the barriers. And I was wondering if there were demographics of the folks who ran into the barriers, and if so, like what were some of the techniques to help combat some of them?
So I don't know if Dr. Dandashi wants to speak on that as well.
Yeah, I mean, I think like that's a very good question. And there are things that were consistent, I would say. One of them is people who have limited English proficiency. And I think that's kind of like, because like if the provider does not speak the same language and they have to bring in a translator, that kind of makes another addition, like a complexity to the visit, to have like a third person in. And we should offer it as providers. Actually, this is part of the law. But what I've seen is that, providers get, like they don't want to do it because it just like become very more complex. So actually there's a study that showed that people who speaks like have limited English proficiency were not offered telehealth as other people. So I think that's kind of like one consistent thing that I've seen. And in our institution, other institutions, and in the studies. The other thing is, I found like definitely the people who are in the older age group, being in tech savvy or not. I mean, the kids, the 20 years old, probably they would teach me how to connect virtual visits, but I think the older folks had like definitely more trouble and barriers with the digital literacy specifically. Then you talk about like, in rural, you have like kind of the issues with the internet and definitely lower income, population, but not specific, I would say, to race or ethnic minorities, because like, I think like for example, like here at the University of Missouri, I have 60% of my population are white, and they still kind of like, we're talking about people who are very vulnerable in rural areas, and they definitely don't have, except like as Aisha was saying, like it's just like that flip phones. So it's really more the socioeconomic status than anything else, and age and English proficiency. I would say these are the most top three things from what I've seen and I've read.
Yes, and I agree completely as well. I think it was more so my elderly patients definitely had a little bit more of need for further navigation, so I would spend a lot more time with them. I don't have exact statistics of how many patients we saw. A majority of our patients were minorities. We saw a lot of Hispanic patients as well as Black patients. That was the majority of our patient population. So demographically, there wasn't specifically really a trend, but more so again on that age side. Some of the patients who are older definitely they had concerns about privacy, as well as kind of just the low telehealth literacy as well.
Thank you very much, ladies, for that.
Well, thank you so much. I think we might have to wrap. We're at just a minute after 1:30 Pacific, 4:30 Eastern time. And I just want to thank both of our presenters so much for a really excellent session. I want to encourage all of our attendees, if you have any other questions, let the HealthHIV team know, and we can follow up with our very excellent presenters. If you have a follow-up question, make a connection if needed, or get more information for you. And also want to encourage you, to share the recording with your colleagues at your site and any others that you think might be interested. And we will be sharing that link with you. It'll be accessible probably within the next couple of business days to share that Zoom recording with you from from Health HIV's YouTube page. So thank you all. And then I think the other note Anna probably would like me to say is that we will be asking all attendees for this series to participate in a very brief evaluation. So we'll be reaching out about that. But again, just want to thank so much our great speakers today for participating. And we hope to work with all of you again very soon in the future. So thank you.